Hello and welcome to this course on communication frameworks for discussing clinical utility of diagnostic tests. This is the first video and the longest video, about 20 minutes long. I'm Bruce Quinn, a Senior Health Policy Specialist at Foley Hoag LLP. You can find this video and other information at my blog, discoveriesinhealthpolicy.com. This first video is an overview of the entire framework. Then there are 3 follow-on videos for people who'd like more information, one focusing on models for clinical validity, one on how we discuss clinical utility, and finally the 4th video works through a number of case studies using the framework as a guideline. Why do we have this course? Too often the status quo is that a payer or health technology assessor says your test lacks sufficient clinical utility, so you need more clinical utility. It's not very clear, not very structured, and you're not certain what to do next. If we were playing the right game, I argue that the payer would say, I understand the value proposition of your test, 30% of surgeries will be safely avoided, but I'm not convinced it will happen. I'm uncertain because of A, B, and C, and this could be addressed if you do A, B, and C work or explanation in the future. This idea of bringing a more systematic approach and more clarity is reflected now in the regulatory space as well. This book by Philip Musin at Janssen is called Benefit Risk Appraisal of Medicines, a Systematic Approach. His main argument being that these risk-benefit appraisals have not been systematic enough in the past, and as a result there's been inconclusive debate for many years without moving the structure forward. Also this year in 2014, the Institute of Medicine, in collaboration with the FDA, is sponsoring 2 full-day workshops called Characterizing and Communicating Uncertainty in Assessment of Benefits and Risks. They say that identifying and evaluating uncertainty is very complex and challenging, exactly the stimulus for the course you're watching. The executive summary is on this side. Today, most commonly with diagnostic tests, we talk about analytical validity, clinical validity, and clinical utility. Those 3 aspects of the test are true. It's like saying a book has weight and pages, then the book is written in a language, then the book is about something. That's perfectly true, but it's not very helpful for knowing how to write a book or whether you want to read a certain book. This set of videos will produce the analysis shown at the right. The main thing is shown at top, a guided analysis seen here with a framework and 6 questions. Then we discuss different categories of tests, mostly in video 2, and discuss categories of outcomes, mostly in video 3. The concept is that frameworks today don't solve problems, and they don't facilitate communication. 2 different issues. We take the EGAPP triad, analytical validity, clinical utility, and we've just expressed that it's perfectly true, but it's not really a tool like a hammer or a pliers to push you forward. The Freiback and Thornberry hierarchy of 6 or 7 levels starts with the technical accuracy of diagnostic tests such as imaging and moves upward to whether it changes diagnosis, impacts decision making, changes therapy, changes the patient's outcome, and what's its total health benefits for society. It's similar to the EGAPP triad, but goes a little higher and lower. There are the levels of evidence classification we're familiar with from evidence-based medicine. Here the highest level is a meta-analysis. Below that are results of multiple RCTs. Below that, the results of a single RCT. Below that, you have observational or cohort studies. And finally, at the bottom, expert opinion. Yet this isn't how we usually make scientific decisions. For example, we know that the cystic fibrosis gene causes cystic fibrosis, and yet that's based only on observational data and expert opinion that the observational data is correct. Finally, if you look at a Medicare national coverage determination, they actually have a structure to those 30 or 40 page documents. And the main structure is they will list the studies they're going to talk about, abstract the studies, Smith 2010 studied 100 patients with this observation and this conclusion. Jones studied 50 patients with another observation and another conclusion. Then they start over and they go through the 20 studies, critiquing each one, what might be wrong with it, and finally out pops a conclusion. Now, the problem with these approaches is that they're nonlinear. For example, you can't just add up the points for analytical validity and the points for clinical validity and know what the outcome is going to be. There are overlapping concepts. There's no clear path through these processes. And most importantly, they seem to fail to foresee or facilitate the identification of disagreements. I would also argue that the problem is not quote unquote defining clinical utility, because the concept of clinical utility is so basic that definitions tend to be just tautological. We might say clinical utility is the incremental value in medical care. But clinical means medical care and utility means incremental value. So we haven't really said anything by creating quote unquote the definition. Well, let's step back a level. How do we often approach really hard problems? Problems that are fuzzy, ill-defined, not sure how to talk about them. It may help to use diagrams. We may sort through them with key questions, or we may divide the problems into categories and deal with each category separately. We'll start with diagrams. If you see the Harvard Law School movie called Paper Chase, here's Professor Kingfield standing in front of his chalkboard, and they've got diagrams on it. They're discussing legal cases, but they're using diagrams. Euclid, of course, used diagrams for geometry. Stephen Toulmin in 1952 wrote a book on the approaches and uses of argument. His work can be represented as diagrams. In the lower left, we have the work of a famous epidemiologist, Sander Greenland, using diagrams to talk about epidemiology. Well, let's try making a diagram for our problem. There is clinical utility, and it's just floating in space. But in fact, we're talking about a new test and an impact on clinical pathways. So there's a gain in clinical utility. It's something that's comparative, and that means we have to compare it to an old outcome, and there's something different about the new outcome. Of course, the diagnostic test is not an outcome, it's just information written on a piece of paper. So it has to have some kind of effect on management, driving from left to right. But what's driving the process? It's the new test. But of course, the new test is not just floating in space. It's some improvement in clinical validity created by using the new test, and that means we're comparing it to something else. So there we have the whole diagram built up one step at a time. I think the value of this diagram is that we can start walking through it one piece at a time, and it unwraps and unfolds some of the problems that happen when we talk about diagnostic tests. I think the key problem is shown in this question. Does your data and story convince a reasonable skeptic of the three features shown in red? Was there a gain in clinical validity? Did it impact management? And what's the gain in clinical utility? I also use the phrase a reasonable skeptic. You can assume that the reviewer is going to be skeptical, but let's hope he's a reasonable skeptic and not just coming up with far-fetched objections. The FDA, in assessing benefits are greater than risks, asks that an expert would be reasonably assured that the benefits are greater than the risks. Assured is a very strong word. If you're assured of something, you're basically certain. But the FDA says reasonably assured. Is there a reasonable assurance? And not just far-fetched hypothetical objections. Another way we can approach really hard problems, and this has a great track record for over 100 years, is using key questions. Robert Koch, a German physician and researcher in the 1880s and 1890s, was a pioneer in the science of microbial causality of disease. But he didn't just stand at a lectern in Berlin and say microbial causality. He provided 4 key questions, known as Koch's postulates, to help define microbial causality, and he won the Nobel Prize in 1905. Austin Bradford Hill, working in England in the 50s and 60s, was a pioneer in modern epidemiologic causality. But again, he didn't just say the words, he provided 9 key questions for understanding and assessing epidemiologic causality. When we talk about key questions, 1 is not enough. If the problem is assessing clinical utility, using one question, is there clinical utility, obviously is just rephrasing what we already knew and does not provide new structure or guidance for communications. 50 questions or 100 questions are too many. 4, 6, 8 questions seems historically to be a good happy median. Let's look at an example of very minimal evaluation guidance. For diagnostic tests, we say the test should have analytical validity, and clinical utility. Okay, that's pretty minimal guidance, although those three things are true. Let's look at this from a totally different perspective. Let's say we were talking about movies. Movies should have a beginning, middle, and end. Again, that's very minimal evaluation guidance. We could have more modular, more structured guidance. Who is the protagonist? Is the protagonist sympathetic or unsympathetic? How are the setting and lead characters introduced? What main challenge does the protagonist face? And so on. Could we have something like that for diagnostic tests? I think the answer is yes. And I'm pulling from an example that was first used by Dr. Felix Frew in 2013. Here he asked these 6 key questions. 1, who should be tested and under what circumstances? 2, what does the test tell us that we did not know before? 3, can we act on the information provided by the test? What's the best case in an ideal situation? 4, will we act on the information provided by the test? What happens in the real world? 5, does the outcome change in a way we find value in? And 6, can we afford it? Is it a reasonable value? Even things that are relatively expensive in diagnostic tests, like the Genomic Health Oncotype DX test, which is a $3,000 test used in breast cancer, it's $3,000. It's not $30,000 or $3 million. So we still have some sense of whether something's a reasonable value. And it turns out the 6 questions will map perfectly onto the diagram we had before. The first question, what is the correct population? The second question, the improvement in clinical validity. The third and fourth questions, can we act on the information? Do we act on the information? And then finally, the outcome in clinical utility, question 5. Question 6 is a meter that shows the impact on finances. It could be anything. It could be dollars per quality adjusted life year. It could be a budget impact model, but there'll probably be some sense of what the heck does this thing cost. Also, look at questions 2, 5, and 6. They're comparisons. And when you have comparisons, you'll always ask against what comparator, in what units, and with what uncertainty. We'll talk about these in more detail. I call the fundamental theorem of clinical utility the fact that clinical utility is always comparative. Now, people already know that, but let's unpack what that means. It means against what comparators, in what units, and with what uncertainty. And because you always will face these 3 questions, we can predict some of the problems that are likely to come up. These 3 questions apply to clinical validity on the left, which then drives clinical utility on the right. Typical issues that arise are shown here. Against what comparators? Recurrent issues are that the developer wants the most impressive and easiest comparator that's acceptable. Payers want the most realistic comparators. They may often see multiple scenarios and they want the most extensive data in population and duration. In what units? This is an interesting one because comparisons always have direct or implied units, even qualitative comparisons. Let me give you an example. I'm house shopping and I'm comparing this house and that house. And I think that this house is better. The units are how pretty I think it is. I think it's 50% prettier, and I'm absolutely confident that I think that. So even in a very soft daily life example, these 3 questions still apply. Now, the clinical utility units can be very diverse, and you read this in Medicare's coverage decisions. They could be survival, less pain, less adverse events, faster diagnosis, or the same impact at less cost, or others. Some units will involve more controversy. For example, a test with much greater sensitivity, people will ask, are you finding tumors that needn't be found? And finally, another aspect where people often disagree and get bogged down in debate is how much uncertainty is there. So let's look at 3 different aspects of uncertainty. There's purely statistical uncertainty. You have a certain population and you get 50% longer survival plus or minus 10%. Purely statistical. There's external validity, or I call here pragmatic uncertainty. Will it work outside the trial? Will it work in rural areas? Will it work with family doctors? Will radiologists in the future have as much training as radiologists in the trial? And so on. And after you've talked about these two things, there's still something that's left over that I call conceptual uncertainty. And we see this a lot with molecular tests. It's probably predictive, but it may be only prognostic. Or the biomarker should be important, but you have a 10-year study begun 10 years ago, and today the drugs are somewhat different. So will the outcomes still be the same? These are conceptual things that you can be explicit about. We're now going to apply the diagram to 4 different hypothetical diagnostic tests. And I want to emphasize these are only hypothetical. They're just examples that I can present in a couple minutes of how this 6-question framework works. If you're really doing this, it would be an hour presentation for each test, and it would be much more detailed. Let's say that we have a lot of men who have a high PSA, they have a prostate biopsy, they have some intermediate grade prostate cancer on their prostate biopsy, and they're not sure what to do yet. What to do next. Several companies are working this area, introducing a molecular test at this point. Who's the population? Biopsy positive prostate cancer. What's the delta in clinical validity? Well, let's say the molecular test has a lower p-value, a higher r-value. Not sure what to do with that, but it also reclassifies 40% of the men. Well, that's interesting. Can we act on this in an ideal world? Yes. If everything's correct, if we believe everything, if there was a clear difference, then we could recommend less men for prostate surgery. Will we act in the real world? Let's assume that there's some data. They did a 300 patient or 500 patient study. They tracked the men for a year, and there was a 30% impact in the real world with real patients. What did the outcomes do? There were 3 less surgeries for every 10 patients. And what are the pharmacoeconomics? Well, there were cost savings in the first year. These may continue, but we don't have any data on that yet. So if you applied these 6 questions to a hypothetical test, you get the impression you can probably answer most of the questions. It's fairly tangible. Hopefully this test will do well with technology assessments and payers. Here's another example. And again, I'm using it as a, quote, for example. This is based on a Medicare coverage decision in October 2013, where they concluded they would not pay at this time for PET scans with new tracers that can detect beta amyloid and help diagnose Alzheimer's disease. How does this test fit into these 6 questions? Well, what's the population? It would be somewhat ill-defined patients with cognitive problems, but those could be very diverse. They're possibly Alzheimer's or probably Alzheimer's, but in some way they're not typical for Alzheimer's, and we don't know what other imaging showed or other tests. How do we quantify the delta in clinical validity? Well, the test will rule out that you don't have beta amyloid in your brain, so you can't have Alzheimer's disease. And it will move around the p-values for your possible or probable diagnoses. Can we act? Well, Medicare argued that there was not a very clear story here. There might be some effect on prescriptions. They weren't sure how definitive or important those were. So the ideal outcome is kind of bogged down. Will we act in the real world? Medicare argued there was no data on that, only hypothetical data, which they didn't find very satisfactory. How do the outcomes change? Well, based on what we've said so far, it's too early to say very quantitatively or in what units how the outcomes have changed. And finally, pharmacoeconomics. Obviously, we don't know, but that could cause unease that the cost per quality might be very, very high, but we just don't know. I have 2 more examples I'll try and go through a little more quickly. This one is non-invasive prenatal testing. This is a maternal blood test to diagnose Down syndrome in a woman who's pregnant. What's the population? Women who would get amniocentesis because of existing guidelines for their pregnancy risk level. So that's pretty clear. How would we quantify the delta in clinical validity? Well, the NIPT tests are extremely accurate and that's based on a gold standard. They're 98, 99% or more accurate. Can we act on this? In the ideal world, sure, we would replace amniocentesis with NIPT blood tests. Will we act in the real world? Yes, in a big way. The guidelines moved in this direction. Women and doctors have already made this choice en masse. I think I've heard 30 or 40% of amniocenteses have switched to the NIPT test. How do the outcomes change? There's much less amniocentesis, but they seem to feel there's equally good data for decision making. What are the pharmacoeconomics? I don't have a study at my fingertips, but a lot of the costs would be replacement costs. You might substitute a $1,500 molecular test for a $1,500 amniocentesis. There might be some value given for pain, risk, quality of life. So the 6 questions suggest this test would do pretty well with payers, and in fact, it's a done deal. It's already done pretty well. A final example is a company in California called Veracyte making a test called Afirma, A-F-I-R-M-A. And going through the questions will tell you what the test is. The population is patients with a thyroid mass, and they've had an FNA to diagnose it, fine needle aspiration, and the result was ambiguous. This happens maybe 15% of the time. What's the delta in clinical validity? The gene panel test resolves malignancy issues in a lot of these patients, and there are large data sets. Can we act? Well, ideally, we would be able to defer surgery. If you don't have thyroid cancer, you don't need thyroid surgery. In the real world, will we act? Yes, there are studies that doctors and patients generally defer surgery based on this test as predicted. How do outcomes change? Unnecessary surgeries are avoided. And the pharmacoeconomics, the company has published some studies. The avoided surgeries are very helpful in neutralizing the costs of testing. And you'd probably give a fairly high quality of life value for avoiding a major neck surgery. So the 6 questions predict this test would do pretty well with payers, and in fact, in a couple years, it had a series of publications, acceptance and guidelines, coverage by Medicare, and coverage by a number of major private payers. Now, those were just 4 examples. They were set up to be clear results. In fact, this isn't geometry. People will still disagree. But now you can say, I disagree with the second half of your answer to question 3, and this is why. So we believe this framework will help guide discussion, reduce confusion when the 2 parties are talking to each other, and that's all we attempted to do. So thank you for listening. This has been 22 minutes. It's the longest video. If you want to go further, video 2 talks in some detail about clinical validity models, things we haven't shown here. Video 3 talks about clinical utility categories, which we also haven't talked about. And then video 4 talks about using this framework with examples and carefully walks through 2 of the case studies that we saw earlier. Thank you.